Hi, good evening to all the residents, all the consultants across the country and across the world. It's my pleasure to introduce my best friend, Professor Dr. Ashima Sharma, who is a professor and head Department of Emergency Medicine at Nizam's Institute of Medical Sciences, Hyderabad. Uh, she's so wonderful that she has a passion to teach emergency medicine, and she has done so many works behind which many people don't know. As part of National Medical Council, as part of National Board of Examinations, she has contributed for emergency medicine in large, and she has created such a way that many students can now be entering into emergency medicine and come out successfully. It's my pleasure to introduce ma'am, and this is over to you to continue with the topic.
Thank you, Dr. Srinath. You know, I always say that probably our introduction and liking to each other is mutual. There is no doubt that I've always shared with you how I got introduced to you and what were my initial issues and sudden stuff. And anyhow, forget about all this. Let me just thank Society for Emergency Medicine of India. It was a long I really wanted to meet all of you. Yeah, I have done some small events with you in your conferences, but there was no online webinar. I was like trying to tell Dr. Srinath, you have let me out, and he has been very considerate and kind of all the we are a little late. I was in Nizam's 10 minutes back and I was just rushing over, so I'm very sorry. And without wasting any time, let me go ahead and just what I'm supposed to speak. So
Ma'am, we lost your screen and voice. You are on mute, madam.
yeah, now sorry, I think so I lost you, probably because I got my internet back and then suddenly it fired back on me. So my screen has to be again shared. I'm going back to my screen, I'm sharing it back, and I'm starting the slideshow, and I'm sure from here we'll have no issues. So without saying any further ado, let me start with you. What I thought would be the best thing I can discuss out with you. So being a resuscitation pro, I thought I'm very sure many of you have already finished your basic resuscitation classes, which is all about BLS and ACLS. So if you talk in AHA language, ALS if you talk in European language, or BCLS and CCLS if you talk in Indian Resuscitation Council Federation languages. So let us go a little more, take a deeper dive into it and look into certain special situations where and one of the situation is which I bring to your notice is this particular map. So do you considering what is happening around us nowadays, won't you be surprised if I say that this is a map which is showing how much rainfall has happened over last 24 hours in this country? And you can see those places which are orange and red alert places, and this is what was just taken from a meteorological website. And going ahead. So when you see something like this, there are two things which come to our mind. One is lightning strikes, other is electric shock. Well, it is not just electric shock cannot happen, just has to happen outside only. Well, it can happen in the house because there can be a loose cables lying around, and the surface may be wet in rains, ground surface, and also obviously there would be some power lines which have downed, and there can be an accidental step over of these lines, or not even step over. The person can be just passing by, and let us discuss out what would happen. So to make my stuff more when I started thinking, should I discuss drowning because it's raining out there, or should I discuss electric shock, I realized I just should check the Twitter. I just looked into what is being reported nowadays, and you can see that just yesterday there was a person who died of electric shock. It is on the left side. This is somewhere from Kashmir, Pulwama district. Then there were in Madhya Pradesh there has been lightning strikes where 3 people have died, and a very unfortunate incident of a 11-year-old girl also dying, who was returning from the school. And when I was reading the entire report, it just hit me somewhere on an emotional note as well, because her parents had told her not to go for school, as already it is a rainy day out there, but she wanted to, and unfortunately she was lost in a lightning strike in the state of Uttar Pradesh. Point is that it is not that it is uncommon. These things are very common. Just the fact is that we are not being presently getting some patients, or maybe we are getting patients out of it from our fields coming to us, but we are not able to recognize because they may come with varied presentations, which we will discuss today. Resuscitation is not about only CPR. Resuscitation is about supporting the airway breathing circulation, understanding the physiology which has gone wrong. So please do not think that it's a CPR class. No, not at all. We are going to take a deep dive into what could have happened to because of these two things, and what could save these patients when emergency physicians like you and are there to help such patients. This is another very hazy slide. Yes, it is, because this was a this is a boy. He's just 20 years old, and you can understand that 20 years old are the potential bread earners. So how difficult it is for parents when this boy with 2 of his friends, obviously same age group, and they went up to the Amer Fort in Rajasthan, and at this moment the rain started, they took shelter in the one of the tomb in the fort. And what he says to the reporter, I'll just read it out for you. I was hit by 3 thunderbolts, one after the other, his voice quivering as he lay wrapped in a blanket in his modest home in Jaipur. He and his trio of childhood friends had climbed hundreds of steps to a watchtower on the top of Amer Fort during a July storm, which also claimed 8 other lives. He says the sound was deafening. It felt like a huge bomb blast. My trousers and shoes caught fire. My limbs became still and I couldn't move. Now, he gave us so much of understanding that what all can happen in lightning. It can behave like a thermal injury. It can behave like a shock wave blast injury, and it can also cause neurological deficits, he says. And let us just go ahead and see that whatever he said, yes, it happens. And from there till today, this fellow is still suffering from psychological issues. He was fortunate enough to survive, where both of his friends were killed in the same thunderstorm. Moving ahead, let us say that what do these electric shocks or lightning strikes do to the human body? Well, friends, it causes a direct effect. Either it is a direct effect of the electric current, either it is the conversion of electric current to thermal injury, or it is the blunt mechanical trauma when the patient is just thrown into the air far apart from where he has touched a live wire. These all things cause what? They cause a lot of tissue damage, they cause organ injuries. But this is where it comes to probably not to our emergencies early. What comes to the pre-hospital and really make our adrenaline get secreted are the respiratory and the cardiac complications, and probably the burns and the tissue injuries which come to us for resuscitation in our resuscitation bay. Let's see how it does. So I just thought of writing it. This is a powerful phenomenon of nature, and it's a complete different form of electric injury. So that means that if you are considering that you have a question writing for those who are students who would be probably writing the exams, that I can fit in whatever is in electrical energy to a lightning strike, you would not be really doing justice to the question. I just told you this as I started, that it is not that in this weather, it is very much possible that there can be down power lines which have not been de-energized. That means that the power is still working, and there can be current leakages from the household sockets and appliances. Very, very common in this particular weather, with a lot of humidity in the walls as well. Well, it's important to know the epidemiology. I'm not into the epidemiology of US and India. Yeah, we have seen the news articles. I'm into what I see. So I feel that electric shock is an occupational hazard sometimes. And in my year, one gets admitted at least every week. One each week we do get. They only tell us stories. They tell us stories of that 40. I am fortunate I came. For mostly 40 out of 100, they die. There is a bimodal distribution of environmental electrical injuries with respect to age. What does that mean? That incidence decreases through teen years. And then again, it increases when adults enter the workplace. What sort of work? Either they are construction workers or there are linemen. And 90% of them are men. Different voltages exposures are there. What do I mean to say is there can be low voltage shocks, there can be high voltage shocks, and then there's always a lightning. So low voltage shocks, like almost in the house. I will just go to the next slide where we will know the practical differences, how to differentiate between these shocks. But where do we see that? In the different environments. So low voltage shock, always household, AC current, mostly the kids, those who have just started walking. And don't we see that most of our houses, when we were growing, there used to be, the socket used to be at least at the height of 4 feet from the ground. But now there are sockets just low below. There are sockets in the mid of the wall with just at 1 feet or 2 feet high. These are the ones one should be very, very careful when you have small kids at home, because most of these injuries occur when they start walking and they want to check everything, the inquisitive nature of the child without understanding what will happen. When it is high voltage. So I was just reading another newspaper a few days back where this particular gentleman runs a pawn shop, and during this thunderstorms and all, the cable fell on the top of his shop, and he was trying to use sticks to just take it off, throw that cable off his shop, and he got electrocuted, and unfortunately he succumbed to the injury. And so these can be tree cable entangles, or it can be utility poles in high voltage injury. And lightnings, as we know, we could maybe out for work, it can be a recreation activity outdoors, and mostly it is seasonal. I was just talking to you about this slide. I wanted to say that anything below 600 volts is considered to be a low voltage injury. And I'm sure all of you know that Indian household, it is 220 volts, isn't it? And it is not the same across the world. This also, I'm sure you know that the Europeans and Americans, they differ from us as far as household voltage is concerned. High voltage is something which is more than 1000 voltage. And when it comes to lightning strike, obviously it is much, much more than that, with a lot of 10 to power 6 zeros to 30. Same is the current. So you can see that in amperes, 240 amperes of current and a less than 1000 amperes of current, whereas 2 to 10 to power 5 amperes of current for lightning has been seen. when it is a low voltage household alternating current, the exposure can be a little prolonged, and you should imagine with me that if someone touches by mistake a live socket or a live wire at home with low voltage, then the flexors of the hand, they go into spasm, and they are more active than the extensors. That is a flexor, that is our response. That is something which we have grown up with. So primitive reflex, I should say, not response. So flexors are so small, so we can't go, the victim can't let go of the current. So it keeps on, he keeps on repeatedly twitching over the live wire. So hence the duration is prolonged. Whereas in high voltage, obviously it is brief duration, and in lightning it's just instantaneous. I'm sure you can understand. And so is the kind of rhythm of cardiac arrest they have. It is ventricular fibrillation, a shockable rhythm whenever it is on the low voltage or high voltage side, whereas it's a total cardiac standstill with an asystole when lightning is the source. Respiratory arrest is and cardiac arrest are obviously hand in hand. So in the respiratory arrest, because of the technique, contractions of respiratory muscles are seen in low voltage. There can be an indirect trauma also in high voltage. And what is that indirect trauma? It is just the mechanical trauma. So you, when you are seeing a patient of such shocks of high voltage, you cannot go work without your basic ATLS knowledge. So we have to keep our ATLS principles while managing this patient, apart from the principles of how will we resuscitate this particular patient in addition to it. And a direct CNS injury is very common, especially intracranial hemorrhages, and so many more, which we will discuss for lightning. Burns are usually superficial in low voltage. They are common and deep in high voltage injuries, but they are not much burns when it is lightning, because it just crosses the skin and it is gone, instantaneous. It does not go deep. Mostly when one is stuck with lightning, it is the first victim is wet. So the skin is just the only path wherein the current, lightning current flows. We will go into it as we further look into this particular phenomenon. And the rest of the kinds of injuries which have been mentioned further would be discussed here. So what are the mechanisms? So for mechanisms, what happens? So if someone gets a lightning strike, or someone gets a higher voltage on a down power line and step on it, or a little behind, further away from it, that is 10, let us say 10 meters, even then there is a possibility of electrocution, which is a fatal phenomena, and electric arc. Now, I'm sure I wanted to put that video. It doesn't look very good. It's a little gruesome, where there's this young gentleman on the railway line who, a few days back, it was circulating in all WhatsApp groups, wherein he gets hit by a high tension power line, and the current just jumps because of the ionizing gas in the air. And he was far away from it, but he got electrocuted and had a big fall behind onto the tracks. We all have witnessed this. Now, apart from this, there is something called as electric flash, which is thermal energy, which can reach much more than 50,000 degrees centigrade. Means 5 times almost hotter than sun. Think of it. It means what is the kind of heat which can be produced by a lightning strike. Going ahead. Yeah, extent of injury can be decided by a lot of things. How much current flew, what was the voltage, what was the tissue resistance. I will come into it. So which are the most resistant are the bone, and which is the least resistant are our nerves and vessels. So what was the type of current? Was this AC and DC direct current? What was the current pathway? Did it include the heart and the lungs, or did it just pass through one side of the body? Means you can check the entry and the exit wound. Obviously, any current will take the path of least resistance, and the duration of contact with that live wire, or what should I say, the voltage body. Okay, now just to bring to your notice is that how much current would cause asystole and how much current is the threshold for ventricular fibrillation. So you can see that in very much in my slide, it is very much there that more than 2 amperes a straight line, whereas 50 to 100 milliamperes is the threshold for ventricular fibrillation. And you can go up, we can go up and just check out that what is the maximum current a person can grasp and let go, which is 16 milliampere. The let go current for an average adult is 6 to 9 milliampere, which is 3 to 5 milliamperes for an average child. And something like 1 milliamperes are not even perceptible and tingling sensation. And that is where back in my anesthesia days, we used to do neuromonitoring, and we also do a lot of blocks giving, trying to identify the nerve locators, isn't it? So this is the kind of current we use. We never give more than, even if we try to maximize it at 5 milliamperes, which is painful, we come down to 1 milliampere to make it more precise that we are into the correct plane. We are outside around the nerve and not into the perimysium. Let's go ahead. You may say that again and again, I am just roaming around mechanisms and all and not coming on the major thing. The reason is that till in my learning, till I don't understand the physiology and pathophysiology, I do not think it is easy to go and start working on the patient. So think of it, what would happen if a direct current effect of current on body tissues? There would be a cardiac issue, there would be a respiratory issue. Cardiac issue is mostly ventricular dysrhythmias, and the respiratory issue is a respiratory arrest. This can, again, we have talked it that the electrical energy can change to thermal energy, and high resistance tissues like bone, skin, fat, they heat up, they coagulate. And obviously that will mean a lot of burns. The lower resistance tissues like nerves and blood vessels, they transmit the current. So, but still there is a possibility of formation of arterial thrombosis and aneurysms, as we will see. There is electroporation. This is an important word, wherein pores in cell membrane will happen if the cause to lead to apoptosis. Mechanically throwing away of the victim far away from the source of blast injury. You all have an idea of what is a blast and how pneumothorax, how tension pneumothorax is, or other events secondary to other outcomes secondary to a blast effect can be there. That can also be in abdomen, wherein there can be shattering of major organs like liver or spleen. Depends upon where exactly the wave is striking. It can EDH and SDH, as we know, if there is a strike of the wave or more onto the head of the patient. Can't let go phenomena we have discussed. We have talked about that repeated twitchings and flexor reflex being more stronger. The patient is it is a prolongation of the contact between the patient and the source, victim and the source, for a longer period of time. Lightning has a little more interesting mechanisms. Oh, that is not a right word, interesting, but I would say lightning has a little more typical mechanisms, which is direct strike. Unfortunate, it can be direct strike. It can be a contact strike, that he was very far away, but where the lightning had struck. But what happened was that he was in contact with some tree or pole where that lightning has, has struck. Now I'll tell you what does it mean. So I remember the parents' words when we were small. So they used to say that when you are out in rains and you are taking shade between some place, do not stand next to the wall, touching the wall. Do not touch the wall. Never question was raised because these were parents' words, but this is why it is, because even if the lightning struck, one can be saved if he is not in contact. Coming further, there can be an electric arc, which we had discussed just now. I was given an example, which is in lightning, which is called a slight flash. And there can be a ground strike. Now this, if all of you have done your ATLS, you have seen that a Lichtenberg photograph is also there. And there's a photograph that while a person is walking and the thunder strike happens, it is carried to the victim by forming a pathway, okay, path into this. Now here the point is stride voltage. So if you are walking and your legs are far apart, then you have will generate more potential difference and will get more chances of higher electrocution or higher energy being transmitted to the victim in case the feet are far apart. And that is another reason why we should train and empower the general public that if they are out in rains on the sort of on the wild open areas, they should not they should be standing in one place, and they should not be touching the things around that. And it is better if they keep their feet together. Going ahead, yes, now we start with the effects on victim, and the effects of victim is all about how does the wet skin transmits the current rapidly. So there are no deeper burns, but what happens is a suspended animation. Well, that means a cardiorespiratory arrest gets because happens as CNS gets short circuited. Now what happens for a shorter period of time? It's the cardiac arrest which happens for the shorter period of time. The moment the current passes off, the heart is seen to spontaneously start as well, whereas the respiratory arrest needs our help. And that is what we will be discussing in further. There is a beautiful term called as chiranoparalysis. Chiranoparalysis is something when this effect is on the peripheral nervous system and vascular system. Paralysis, we remember Faizuddin. He said, I was not able to move, and my legs felt heavy. This is what was happening to him. He was having chiranoparalysis. Now, fortunately, these are short-lived effects and they go. And that is what he said also in his further interview, that after some time, I thought I could get up and go off and move off. And that is how he moved, and he could get help for his friends. Unfortunately, they were dead by that time. Mottling and cyanosis is also seen. Now we understand why cyanosis. There might have been a period of respiratory arrest. Autonomic system is also very important, involved in these sort of injuries. What does that mean? That the patient can come to you with a fixed, dilated, asymmetrical pupil. So anyone who comes to me with a fixed and dilated pupil, I know my team says, oh, dilated, but not reacting like. So we start talking about saving the organs, isn't it? And if it is asymmetrical, then we start thinking about sending for a scan and calling for the neurosurgeons. That's it. But here, these things will not have any brain injury. So you send undifferentiated patient who is brought to you, and there is no way you know that he has been at this sort of exposure, and he has asymmetrical pupil which did not show brain parenchymal injury on the scan. A very, very high possibility in these days that he might have been stuck with lightning. Same as shockwave. Shockwave is something like a blast effect. I told you, 5 times hotter than the sun, and at almost at 20 atmospheres. So it can cause rapid heating of surrounding air, and that can cause us major thermal injury to the victim. Now we talked everything in general, and but we arrived into some idea that we are having this victim who may be seen with a cardiorespiratory arrest, who may be seen with dilated fixed pupils, who may be seen with asymmetrical pupils. These were the findings which can make us a little more, which will make us active to start resuscitation. Apart from that, we can see them coming with dysrhythmias. 15% most common presentation, almost most common presentation is cardiac dysrhythmias. If it is sudden cardiac death, it is mostly asystole, but or otherwise it can be a ventricular fibrillation, as I have discussed with you when we were talking high voltage and low voltage and the lightning slides. Sometimes when the patient comes, at that time, ECG is perfectly normal. But few hours later, it has been seen in anecdotal reports that sinus tachycardia, atrial fibrillation, and premature ventricular contractions can be seen. Now, there is a dogma of cardiac death due to respiratory arrest in lightning. Now, what does that mean? What is this dogma about I'm saying? I'm saying that sometimes the heart would have started it is instantaneous, less than 1 second, and though it causes a cardiac standstill, but the moment it washes off, it means the electricity, it washes off, the victim's heart may have started, but the respiratory arrest takes a lot more time, and therefore it is the respiratory arrest which would further again cause a cardiac arrest, and that is why the patient may have issues. So this is what it is. It is initial cardiorespiratory arrest followed by a spontaneous recovery of cardiac rhythm, followed by a re-cardiac arrest because respiratory arrest was not managed. Apart from this, there are certain conduction disturbances like first and second degree AV blocks and bundle branch blocks, which have been noticed in these individuals as they have arrived in various emergency departments. And the reason is very obvious. I just kept the reason for the fact that there might be many students who are interested to know that the anterior location of the right coronary artery leaves the sinus and AV nodal arteries very vulnerable for getting electrocuted, and therefore these blocks are also seen. Now, as I said, we cannot leave behind the fact that these patients can have trauma, mechanical trauma, because they can be thrown apart, they can be a shock wave, they can be a blast lung, blast injury. Therefore, cardiac contusions are also seen. And these patients would definitely require, I think so, if they have a cardiac contusion, which is massive, which is causing a pericardial tamponade, we might have lost them on the field. And if they come to it, same way I would come to know that there is a pericardial tamponade, the wave is ATLS. The circulation would be put me suspicious of instability. Hemodynamic instability will make me suspicious of the diagnosis. And there is also, it is also seen that when you do a POCUS, in your red triage, for such patients, there is a possibility of finding some focal regional wall motion abnormalities, which is, and the diagnosis later on, it's not a diagnosis which you can do here because it's a diagnosis of exclusion, the broken heart syndrome, the Takotsubo cardiomyopathy. Neurologically, they come with respiratory arrest, they come with a respiratory arrest, which has definitely been given some rescue breaths by a pre-hospital person. Then only they would reach us alive. But if there is apart from that, the victim may be fortunate to just have a peripheral nervous system involved, wherein the motor the deficits can be patchy with sensory deficits not corresponding to the motor findings. What is more interesting is there can be a loss of consciousness. There can be some neuropsychological sequelae, as we had discussed. There can be memory disturbances long term. It is not my or your headache, but yes, they may keep on coming back. You know, they can come with a lot of psychiatric issues at some point of time. And hypoxic ischemic encephalopathy, if they were revived after say of 3 minutes, or the time when the time for neurological injury has already set in. I told you about intracranial hemorrhages, and I'm sure that mechanical trauma can cause spinal fractures, which you and I can see. So again, here I've added up to those pupils issue to that this patient can come totally comatose. This case patient can come with a lot of spinal fractures. This patient can come with after some time with memory disturbances, or it can come after some time with neuropsychological issues or psychiatric emergencies. And also, as I've said, intracranial hemorrhages. So you can understand that as we work for any other patient, if the history is not available, same is how we work for these patients. There are some things which still can help us, and I'll share with you one case where our neurologist could identify this in the following slides. So there are burns which can happen in all variety. By variety, I may say that they can be superficial, partial thickness, full thickness, contact point burns. The more the blisters, swelling means more severe charring. But here the analogy is tip of an iceberg. So can you see this face? This photograph has been taken from NAGM 2000, where this particular child had a burn on the oral commissure, and you can see that it does not look so bad. But in 2 to 3 days, when this eschar came out, the labial artery bleed was uncontrolled, and it led to a major hypovolemic shock. Thankfully, the child survived with the urgent intervention. But what is needed is that if with such sort of burn, please do not be easy on the to tell that no, it's okay, this will heal by itself. Definitely take a plastic surgery consult, or tell them that this would be a problem in just few days. Okay, they can be kissing burns, which are on the flexor surfaces adjacent to joint. Oral burns, I've told you. Flame burns means nothing. It means that someone who has got this electrocution, has wearing jewelry, can have a sort of an imprint, or because of the thermal heat, or because of the current being passed through the metallic jewelry. And the one which I've listed in work, as I've shown it as a fern-like picture, fern pattern-like picture on the back of the patient. No, it does not stay forever. It is just for a matter of 2 to 3 days. It takes care, resolves spontaneously. And this is also taken from one of the books only, because I have not personally seen any such fern-like pattern yet. Okay, so we move to other sort of injuries, which are more of either because of the high resistance of the skeletal system, which causes periosteal burns, osteonecrosis, or destruction of bone matrix, or the fact that there is a major injury below, tip of iceberg. What was seen above was not the story, what did not tell us the whole story. The story was the compartment syndrome below. And I'll tell you what our book Tintinali says. It says that even for 1 second, less than 1 second rather, it says, if someone is exposed to this sort of injury, this sort of electrocution or lightning, there is a very high chances of compartment syndrome. Rhabdomyolysis comes along with it. I'm talking of muscular injury. I'm sure you have understood. And with rhabdomyolysis and compartment syndromes, renal, pre-renal azotemia and ATNs are very well known to set in. Well, this is where we found out. So there are, farmers, they have a sleeping back in their in the field over the night, probably looking after their grain stock or this. And so we had an elderly gentleman who came to us with ICH, and he had we did not know. So what we started thinking, Russell viper bite. Oh, it must be a vasculoskeletal vasculotoxic snake. No, he was sleeping in the open. Oh, we could not find any bite mark, but still ASV is good, better to give it early than to repent it later. We gave. Then we thought, okay, he must have an hypertensive bleed or something. We were doing all these things. We were thinking all pupils were core-dilated. Okay, now with core-dilated pupils, obviously no one else gets very interested in such cases. And his age was also on a higher side. Then I should say that one of the neurology residents took up that otoscope and he looked into his ear, and he found there was some reddening. I would not say that, but he found a ruptured tympanic membrane. Okay, now it was ruptured in a sense that it looked very acute. It did not have those edges where, you know, chronic ruptures, they will have, the edges would be rounded off, and there would be a history of a lot of discharge, chronic CSOMs, which he did not have. And this ruptured tympanic membrane gave us a little clue that this could have been a patient who was struck by lightning. And this happened some 3 years back, just before COVID. And it was a good case. And I'm sure that if we apply such small anecdotal reports, we can look into a lot more cases which have not been reported. Probably the newspaper reports the deaths. Probably we can report those who we save. Apart from that, there can be sensorineural hearing loss, tinnitus, vertigo, and facial nerve injuries. On the eye side, there can be a traumatic cataract, vitreous hemorrhages, hyphema, optic nerve injury, and retinal detachment. Okay, so that means that in any case, undifferentiated, where you are not able to understand what is the reason of this loss of consciousness, it is very important to look into learn the art of seeing the eye, fundus, and also if there is some clue to the history that obviously season, that it can be lightning strike, do check for tympanic membrane and facial nerve injury. Okay, going further, I said there can be vascular injuries wherein though vessels are least resistant, but they can cause delayed arterial thrombosis, aneurysmal formation, and rupture. Now, obviously, it will not happen when the patient would be in emergency department, but finally the patient will come to the emergency department only, is it not? So no, I would not say that we will ask every aneurysms that whether you were struck by lightning at any time. But for students, if they are telling what could all be the causes of such cases, it is important that they should remember it. Okay, there is a masking of mesenteric ischemia in most of these cases, which can happen, but it stays masked because of a lot of other paraphernalia of symptoms going on. So we have to actively look for it. And there can be some fistulas, which can perforate, and all of this is more of a blast injury effect, isn't it? So coming to something which we are very passionate about, that is pre-hospital consideration. So this is called as scene safety. So when you have, by any chance, any one of us comes across someone stuck to an electric pole, fallen from an electric pole, still in contact, be very careful. You have to make sure that the scene is safe. Or if there is some downtown power line, it has to be de-energized, then only enter. Our lives are more important. And there is something called as, which I would say that I've seen people not realizing, and I've seen that it is also mentioned in books, is what is the kind of boots and gloves which are safe. It is not that if I'm wearing rubber slippers or some fancy boot, it is safe because I'm not wet going without slippers. No, and same is with the gloves. There is a special kind of these boots and gloves which are there for these people who are into line, especially the linemen. You have seen them probably. They are the big gloves and the big boots, and they have been time tested that they can take care of these injuries. I mean, they can take care of the provider not being electrocuted, which also means that all the ambulance service providers should have this if they are thinking of sending their ambulances nowadays, which is the season for all this sort of injuries. Yes, I am very much worried that simple wooden sticks pick it up and try to separate the victim from the voltage source. No, it just because it is a wooden stick does not mean it cannot. It can make the path, and it can make the provider also being electrocuted. So this is also very important for us to understand. Now, what is more important here is probably the fact that I've written reverse the triage process. Oh my God, what was my triage process in mass casualty? So if I see someone let us say, if I am there at Amer Fort where there were 11 people who got electrocuted in one time, what was the reversal I was thinking on? Isn't the try just do the best good the people who will survive? Yes, is that so? Yes. But here, what is their sign of life is should not be taken into the point where you will intervene. Why? Because you have seen that there can be a cardiac arrest which will become spontaneously be back to normal. So we have, if we give a respiratory rescue breaths to the patient, obviously after seeing is safe. And same is that there can be asymmetrical fixed dilated, co-dilated pupils, but they can also be back to normal. So here the triage process should be that those who are looking more sicker, if there is no breathing, you have to give rescue breathing and don't move forward, because these patients will definitely survive, as we have talked about the dogma of lightning strikes. And the fact is that okay, so the age old, there was lightning strike only once. No, it can strike twice at the same place. So the provider should be taught to leave early. Don't start doing things over there only. Manage your patients as you are going. What do you call it? Scoop and go, run fast sort of stuff. So do not stay there, because lightning can strike twice, and we don't want to be caught into that scenario. Okay, coming to hospital ED, CPR team stays the same. Their steps stays the same. So I'm not going to put my effort into it, but I will tell you that you can prolong your CPR. So what do I mean by prolong CPR? So normally 15 minutes or 20 minutes is when we start thinking at that, okay, let us hold on. It is not going anywhere. We are not able to achieve ROSC. But here, regardless of initial rhythm or pupillary dilatation, there are anecdotal reports that these patients may, if you do keep your CPR attempts ongoing, then they may have a good outcome even after 45 minutes. That is what I read in one of the anecdotal report. Early intubation, yes, be it rescue breath, be it putting in an LMA or an iGel, whatever you are comfortable, or probably doing a direct intubation in this patient is what is very important. Now, this case-to-case basis. If you feel that you would be losing the airway because there are a lot of words on the upper chest and all, early intubate. So definitely the crux of thrust is on the fact that respiration needs to be stabilized. How do I do a primary survey of this victim after I achieved back the ROSC? I go as per the ATLS rule. I do the ABCDs of this patient, because I am very worried that this patient can have a burn injury, can have a mechanical trauma, and anyhow, I have taken care of rest of the stuff. That is why he is alive at this point of time. Okay, my primary survey achievements for always ECG, ABGs, 2 tubes, isn't it? So it stays the same. But if you can see this ECG and a lot of tall T waves which are happening in this ECG, one can be a little worried what is happening over in this ECG. Well, these sort of changes are very common if the patient is ECG has been telemetry to you, or it has been the patient has arrived early to the ED, but this all settled. Even this ECG settled within 30 minutes, as reported by the doctor who has done this. Again, this has been taken from the web. I would say I would do ABG because I want to see the electrolytes, and I also want to see the PCO2s. Now, why PCO2s? If I have an ETCO2, no, but my PCO2 is for my after ROSC. One should do an ABG, as you know, and PaO2s are important again because there can be a lot of blast lung injuries. Urine for myoglobins, creatine kinase for serum levels, troponins for knowing if there is a cardiac contusion or any other cardiac injuries, a CBC and a renal function test for urea and creatinine, because we discussed that there can be a prerenal azotemia. These all are type of tests which we said. Now they can be case-based, depends upon case to case. There is no hard and fast rule. I work in an institute where active burn cases are not taken. I'm sure those who are at Hyderabad know that Nizam does not do burns, but we do a lot of burns when they come with disfiguration, or that is the time when we intervene, but no acute burn unit. So we have to give this protocol to our students that which patient you will shift to burn unit. So if there is a high voltage burn or an alternating current burn, which you think will require fasciotomy, eschorotomies, extensive skin reconstructions or limb amputations, please go ahead and refer them to Gandhi or to any hospitals. Well, there is always another thrust on this, that we tend to write a little more antibiotics than are required. It is a controversial topic. Do as your microbiologists say. What I would suggest is that if there is a burn injury, there might be an underlying compartment syndrome, as we have talked about. And this can, Clostridia is one thing, one organism loves to go in a devascularized muscle tissue. So penicillins and a lot of the type of penicillins are good enough for taking care of your patient. A general surgery reference is definitely needed. Deep tissue injury, we base it on creatinine kinase levels. If it is more than 400, we know that there is a deep tissue injury and it requires debridement. And if it is more than 500, then we tend to take a decision whether the injury is so much that it may go for amputation. But again, this is not a hard and fast rule. It depends upon further evaluation only. Fluid resuscitation is very important. As I said, we go by ABC. These are just some basic questions which we are discussing. So Parkland formula, 4 ml per kg to the multiplied by the percentage of body surface area given over 24 hours. Yes, but Parkland is only about the superficial burns which you can see. There's a lot more happening inside, tip of the iceberg. So therefore, liter per hour takes care of the myoglobin washout, prevents a pre-renal azotemia. So start with the Parkland if you are confused. Stabilize your patient and then go ahead and do call your consultant or the help you have, and probably one has to hike up the fluids to make sure at least 1 liter 1 to 2 ml per kg urine output is there for this patient. Certain special investigations like technetium 99 scan. So we have a nuclear medicine department. It's a little easy for us. And that is when we have on the top, there is just a small punctured wound, but the patient has severe pain in that leg and he is like not moving it. So what we do is we do a scan to find out the devascularized muscle tissue, and this sort of scans help us. But again, it is more of surgical investigations, and very, very less often they go from emergency department. So I would end this here by saying that I wish you all safe rains, enjoy yourself, but be very careful and empower your paramedics. That is what we look forward. I'm so sorry if I've taken more than the time. So questions, my mail, and thank you.
Yeah, there's one question, ma'am. Does calcium gluconate have any role for membrane stabilization in these cases?
Okay, so calcium gluconate, I think so we are talking about the role of calcium gluconate in when we have hyperkalemias. Obviously, yes, but what are we talking about here is the membrane pores in the cell membrane, which is causing a lot of cell apoptosis. Whenever the cell membrane is lost, the cell is lost because it is a semi-permeable membrane. So I would not be giving calcium to these patients for lightning patients just because I want to keep the cell membrane stabilized. There are a lot more things one can do.
Okay, if anyone has any more questions, they may post in the chat box. So how to find for exit wound in electrical cases?
Okay, Okay, yes, there is a need because it only tells you the path of the current, isn't it? You need to know the path of the current because you need to know which muscle, where you want to need, where inside there is an injury. So yes, you want to. So how to look for it? So I just gave you a little hint of a technetium scan, which tells us, or then exposure. It is all A, B, C, D, E. So remember, most of the time, if it is the left arm of the victim which has touched a live wire, or left leg which has stepped over a down-toned wire in this so much of this, it will cross only on the one side of the patient. So it is exposure in primary survey where we will look for it. If there is any particular way of looking for it, yes, we will leg roll and log roll and look for it. We'll definitely stabilize the spine. I did not go into those depths because I thought you know how to, we all are in the same phase, how to do spine stuff. So, but I don't know. I'll be very clear to you. I do not know, is there any particular algorithm to look out for exit wound? I'll just log roll and see it in exposure. And I need it only to know how much is the muscle injury. That's it.
Okay, I don't see any more questions. Thank you so much, ma'am, for joining us.
Thank you.
And
Thank you so
glad
much.
that your internet is back with good speed. So
Yeah, it was
it.
initially, it was not there for 5 minutes, 4 or 5 minutes.
Yes,
But
yes.
then it worked. So I don't think so. In between my voice.
Yes, now it's.
So thank you again
ma'am.
for all of you, and happy reading, and all the best for those who are exam going. All the best for those who are practicing. Super wonderful. Thank you.
Yeah, if
Can I-
anyone wants to get notified about the future webinars,
But let me thank Dr. Talha Hussain once. Thank you, Dr. Talha. I keep on following you on Facebook. You are roaming around in London. I know that. So we'll talk. So thank you all, and yeah, bye.